Great. Thank you, everybody, for joining us for this exciting ATI seminar. My name is Dr. Young Lam. I'm one of the transplant nephrologists in Calgary. And I'm going to start with a land acknowledgement, and then I'll introduce our speaker. We acknowledge that the University of Alberta is located on Treaty 6 territory and respects the history, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. I'd also like to thank Paladin for their support of the ATI seminar series. And it's my pleasure to introduce Dr. Lorenzo Gallon, who is a professor of medicine and surgery at the University of Illinois in Chicago. He is the director of the abdominal organ transplant program at UI Health and completed his medical school training at Padua Medical School in Padua, Italy. I hope I said that city right.
Yeah, that is fine.
Okay, and followed by completion of his internal medicine and nephrology training at the Brigham and Women's Hospital at Harvard Medical School. He has served on the editorial boards for Clinical Nephrology, the Journal Nephrology, and Nephron. Dr. Gallon's primary research interests include the role of immunosuppressive medications in modulating the immune system, genomics of chronic renal allograft rejection, chronic kidney disease after liver transplantation, prednisone-free and calcineurin inhibitor-free immunosuppressive protocols, aging and exercise after transplantation, and biosensors and biomarkers to monitor kidney transplant health and prevent rejection. And that last one is what we're going to be hearing a little bit more about today. Welcome, Dr. Gallon.
Yep. Thank you, Dr. Lam. It's really a pleasure to present this data today. Even if you're far away, far apart, I hope that we can keep some connections. So yeah, my talk today will be novel approach to post-transplant graft assessment with biosensor and biomarkers. So I will give a little bit of an overview of the problem, which most of you already probably know, and then I will dive in biomarker that are commercially available to us today, and then some of the work on biosensor that we have been doing with the two institutions also right now, presently in large mammals. So these are my disclosure slides. So the problem is that we have about 50% US population that are estimated to have a chronic kidney disease. In US, there's about 37 millions, with about 100,000 of patients that are attached to a machine, a PD machine, or hemodialysis machine. About 100,000 patients or so are on the waiting list for kidney transplant. We're able to transplant only a small percentage of those, about 20-25%, depends on the year. Last year, we have a blockbuster years, which we transplant about 26,000 individuals. What does it mean to have end-stage renal disease? But I don't think I need to tell this audience about that. But I want to just point it out that being on dialysis or PD or hemodialysis is associated with a higher risk of mortality when compared to colon cancer and breast cancer in female and colon cancer and prostate cancer in male. So it's a very bad diagnosis to have. So what we do, well, we do know that if we transplant individuals, we increase the life expectancy. In fact, the United States renal data shows that 5 years patient survival after a kidney transplant is about 80%. And if you stay on dialysis, the survival goes down to 35%. So really change completely the landscape of how much you're going to be able to live after if you stay on dialysis or if you get transplanted. Unfortunately, we cannot transplant everyone, despite effort to go through obviously xenotransplant, which probably will be, in the future. The truth is that we have an increased number of patients listed every day waiting for a kidney transplant, about 100,000 or so I showed before, and we have very minimal amount of patients being transplanted through living donor kidney transplant, deceased donor kidney transplant. Now, few words about living donor kidney transplant. In US, it's been stagnant indeed. We are struggling to convince people to donate kidney, and unfortunately, because the aging society, we are very often use kidney donor that have marginal or poor quality donor. So we are dealing two problems. Number one, not having enough kidney for everyone. Number two, actually three problems. Number two is not to have enough living donor. And number three, to really use kidney that are really marginal. And even though we've been using different immunosuppressive strategies, different medications, CNI-free regimen, the truth is that long-term allograft survival has not really changed drastically over the different time frames in different strata. You can see they're basically parallel to each other, and most of the kidney eventually will get lost over time. And even though there are multiple reasons that we know that this will happen, nephrotoxicity, infections, so on, truly the most important factor is the allo response against the graft that can induce acute rejections or chronic rejections or both. They're linked to each other. More rejection you have is quite being evident already by multiple publications. Acute rejections, antibody-mediated, T-cell mediated rejection, they all associated with significant reduction of EGFR and graft loss. And this is true also for subclinical rejection. This is work done by Alex Lupi from Paris that shows clearly, and others, that if you have subclinical rejection, which, as you know, is histological evidence of rejection without raising the serum creatinine and being diagnosed by protocol biopsy, really, if you have antibody-mediated rejection or T-cell mediated rejections, your GFR will be much lower compared to patients with no rejections, and as a consequence, also you're going to have an increase of graft loss over time. Another big problem that we have is that even when we recognize rejection with biopsy, we treat the patients. A big issue is that if we re-biopsy the patient after therapy, it depends what kind of therapy you want to implement, thymoglobulin, steroids, a combination of both, anti-B cell agent, if somebody has an antibody-mediated component. If you re-biopsy those patients at later points, which again, we seldomly don't do, more than 50% of these patients have still ongoing rejection or immune response against the graft. This is work done by Pittsburgh's group with Rothstein and Fadilakis and other people there. So this is important. So we also assume, to some extent, that the treatment of rejections means the cure, but we don't. In fact, this is the proof that we are basically dealing with an ongoing immune response despite the immunotherapy that we provide to our patients. So how do we monitor today this quite precious organ, the kidneys that we have? We don't have so many. I showed to you where they are going through rejection episode. We have really two ways of monitor at the moment. That one is serum creatinine, as you all know, and we monitor by taking blood sample frequently after the transplantation, 3 times a week in my center for a few months, and then we scale down to once a week, and then eventually after 1 year, once a month. But as you well know, serum creatinine is neither sensitive or specific for an allo response or damage to the kidney. It goes up in many other events, such as is a filtration marker. So it goes up if you volume depleted, if you medications and so on. So that is one of the issues with serum creatinine, even though it provides information to us, we use it all the time. And then another way to do is kidney biopsy. Obviously, having a kidney biopsy is the gold standard to make a diagnosis of rejections, but is associated with an invasive procedure, anxiety to the patients, complications such as bleeding, heavy fistula formations, and then sometimes even sampling error that you can take maybe a part of the kidney where there's not really a problem that you might need it to evaluate. Going back, I guess, to this, that Bruce Kaplan and Jesse Schultz a while ago published this paper that the doubling of serum creatinine really doesn't provide information to overall graft failure after 2 years. So again, serum creatinine, even though it's an important marker, it doesn't really predict too much what's going to happen to your kidney if it doubles up. So unimportant information. So that brings me to the question how we can deal with this, right? So how can we use a personalized or more targeted therapy diagnostic to our patients? And I want to start with an example outside kidney transplantation, which is basically lung cancer, to show how much improvement has been done over the time in this disease. In the 1970, 1980, if you had lung cancer diagnosed by chest X-ray, you received chemotherapy, and your benefit of chemotherapy was negligible. I mean, you basically survival was about 4 to 8 months after chemo. Now we fast forward to 2023, and low dose CT scan for early detection high risk patients, smoker mainly, was implemented. And then targeted therapy based on mutation within the cancer was done. And now at that time we start using the first EGFR and other anti-cancer medications that really modify drastically the therapy for cancer, diagnostic for cancer, to the point that patients now were living up to 2 years after the diagnosis with a 20% reductions in mortality. Then go to 2015, with the use of autoantibody when you do CT scan, and then with looking at PD-L1 expression on the cancer, you start having immunotherapy, the checkpoint inhibitor and other medications. And again, this eventually change again the landscape how to treat cancer with having patient now survive with up to 5 years. And now with the AI integrated management of these patients, in other words, when you do chemotherapy, when you do immunotherapy to patient with cancer, you have to do repeated CT scan, and the CT scan show inflammatory process or recurrence of cancer. AI can actually deliver all that information to the point that right now, patients are entered in a AI-driven therapies. So if they need extra therapy, all this new technology will provide them the proper. With eventually the future obviously will be to cure the disease. So in relatively I don't know a few years, I don't know, but you can see how much in this particular disease diagnostic and therapy have changed the course and for the patients. So I borrowed a couple of slides from Martin Nissen, which is a friend of mine, and so what we want to do in transplant is pretty much similar to what we want to do for any other diseases. So we want to go from traditional medicine, traditional approach of diagnostic and therapeutic, the medication we have, to more a personalized approach to the patient. With the diagnostics tool, biomarker can really help us to treat specific group of patients and treat other patients with other medication or other diagnostic tools that we have available. So this is really the goal. And to dive in more in detail is what we want to do. We want to have marker in the blood that can infer information of what is happening in the biopsy, right? At the end of the day, the biopsy is a gold standard information for us to understand what has happened to the allo response against the graft. And so in other words, the blood becomes a mirror of the graft health. An incredible amount of work has been done by doing mRNA profiling of biopsy, but the group in Edmond, Philip Alvarez's group, has done tremendous amount of work that even has changed the classification of BAMF for some of us, and even in some cases, what the eyes could not see with the MDDX, actually we can actually understand the process much better right now. So incredible work. The problem is that when we try to move these to the blood, we have just a faint mirror of what is happening to the graft. When we try to do the same in the blood, what Phil has been doing in the biopsy, we cannot find the same level of clarity. And in fact, most of the time, it's a little bit maybe more confusing, the clarity. But I think we need to keep working at this. Some of the genes that are upregulated in the blood or downregulated, they're actually being found in biopsy by a molecular microscope, but not all of them. So that is really one of the big issues that we need to address. But it's not really impossible. Indeed, if you look at this paper published in 2010, the AlloMap Heart, they were able to do to show that this is a patient with cardiac transplantation, no kidney. But if you do a biopsy on the heart, which obviously is very invasive after transplantations, but at the same time you do gene expression profile, in this case they have 11 gene, they were able to show that a strong correlation of the data on the biopsy, data on the blood, to the point they were able to manage these patients to some extent similarly with gene expression profile of the patients and without doing the biopsy. And this is something that in some transplant centers is done routinely right now. I was asked a couple of years ago to put together the logistic of biomarker in kidney transplant for the ATC, for the AST, with the idea to put together eventually a paper to discuss this. And I create a couple of tables, and I'll show you some of the tables. I want to make some points. So in kidney transplantation, we have cell-free donor DNA, which, as you know, is is DNA released by the kidney in the peripheral blood that you can measure. And there are basically 4 companies there. I mean, AlloSure Kidney, Prospera, the Track and TheraSure. Only two really are the one we use the most, by CareDx and Atera, as you know. And the take-home point, beside the test type with the Bayes and SNPs, is what information this test provides. You can see here the PPV, MPV, and I put it there. So they all perform quite well with MPV, 95%, because the prevalence of rejection is quite low. So every time you have a low prevalence, you have a high MPV, MPV, correct. But when you look at PPV, it's a flip of a coin pretty much, right? So this is something to really take in consideration every time you order this test. The no FDA approved, okay, the CLIA certify and CMS approved, but the turnaround time is quite long. It's about 2 to 6 days most of the time. And the price is very high. I don't know how much it costs in Canada, but in US it's about $3,000 every time you order this test. So this is a very expensive test that if you implement routinely in our patient post-transplant, it's going to cost Medicare or private insurer a lot of money. So this was the table that created. Then we also have obviously blood-based genomic testing, and there are 5 of them, but 2 already are out of the market, and we'll talk about them separately in a moment. So there's a key sort, the TrueGraph, and I will discuss this, the AlloMap Kidney, the Tutivia, and the Clarava, which is the only pre-transplant test that now will be commercialized by Thermo Fisher soon. So the test type is a qPCR for KeySort, microarray for TrueGraph. AlloMap Kidney basically is a gene expression profile, Tutivia gene expression profile driven by AI, and Clarava also gene expression profile. I go back again by the information provided. All of them, they have a very good MPV. You can see at 99, 89%, 78%. I mean, let's not, I will discuss about KeySort in a second, but most of the PPV are still a flip of a coin. They are CLIA certified, no FDA approved, just to let you understand what means FDA CLIA certified. FDA approval requires a much more stringent data to provide to FDA to approve a test, where when this CLIA approval or CMS approval, you need to provide data, but the review process is much easier than get an FDA. Still, the price is quite high. I mean, $2,000 to $3,000, and with turnaround time from 4 to 5 days, you can see here. Now, AlloMap Kidney is no longer on the market, so we don't need to talk about this. Clarava is the only pre-transplant test. I will briefly say something, but I don't think I'll concentrate because today will be mainly post-transplant. And the KeySort is out of the market. It was not able to validate in Europe. The 2 tests really that we have right now is the TrueGraph commercialized by Eurofin and the Tutivia commercialized by Verici. So I just put this time-based assessment of current biomarker with divide them pre-transplant and post-transplant. So what do we have pre-transplant? We have obviously the HLA matching. We have the PERCH score, I will say something. The PRA and the Clarava Petra is commercialized name. So, and then we have all post-transplant standard of care testing that we do. We always check serum creatinine, we check DSA, immunosuppressed level. We do protocol or biopsy in center where protocol of biopsy is part of the regimen for cause biopsy. And then we have a bunch of other tests coming to us right now. We have a urine test, CHECK10, we have cell-free donor DNA, we will discuss TrueGraph, Tutivia. Then we'll focus on biosensor for the work that I've been doing. And obviously we have the molecular microscope by Phil Alloran's group in Alberta. So a little bit about PERCH. I don't know how much you guys are using PERCH in your institutions, but obviously you can have a typical genotyping of donor recipient pair with a mismatched HLA antigen, and then you kind of like 6 antigens mismatch. You might decide to give more immunosuppressed therapy or more inductions. It depends on the center. But right now, there's a molecular compatibility with molecular typing is still looking at basically mismatched peptides, and the mismatched peptides can be calculated through a score which has been started many years ago with Peter Nicholson work and others that can really help you predict theoretically the risk of activating T cell against these mismatched HLA peptides. Now, routinely, this particular test is being used is a software. It's not really, you basically do the typical HLA typing, and then you insert the HLA antigen in a software, and the software will provide a score, right? It's about $700 to use it per every time you use it. So it's not cheap. So typically in center where they have multiple donors, one recipient with multiple donors that come forward, you can use this and then decide which donor you would like to pick for that particular recipient. But in my case, most of the time I have one donor, one recipient, so it's not like I can do this routinely because it's not going to help me too much. But one thing that I think Perch can potentially, this has become a study that needs to be done, a research study. How can we use the Perch scoring system to help us to manage immunosuppressed therapy after transplant? Can we use low Perch score to minimize exposure to some drugs that tend to be toxic for the patient, so on. So this is something that obviously needs to be done if indeed the Perch score is important and probably will need to be validated in that regards. We still don't know what is the cutoff for the score that indeed put the patient at risk for more or less rejection. There's a lot of work that needs to be done, but the technology theoretically is there. We need to do the work. Now, let's move to cell-free donor DNA. This is an important paper published by Roy Bloom in 2017, which clearly shows that if you have antibody-mediated rejections, the cell-free donor DNA goes up. But then when you have T-cell mediated or borderline changes, you have a lot of unsensitive tests, and you're unable to pick up. You can see all this rejection here that really don't have an elevation of cell-free donor DNA. Now, and we know that, in fact, in my center, I usually tend to use this to look at an antibody-mediated rejection, less T-cell mediated rejections. A recent study by Jonathan Bergen from University of Maryland showed basically in the proactive register group, they identified 424 patients who had a kidney biopsy, at least one cell-free donor DNA within the 6 months prior to the biopsy. Identified 26 patients with antibody-mediated rejection, 62 with T-cell mediated rejections, and 36 with no rejection. And they found that cell-free donor DNA was elevated up to 4 months prior to the biopsy-proven antibody-mediated rejection and 2 months prior to the biopsy-proven T-cell mediated rejection. So, they found this fact that the cell-free donor DNA goes up before rejections occur. And this is in line also with some of the data that Philip Aron with the trifecta study did, that a correlation with some cell-free donor DNA and the molecular microscope. Now, they were able to show this correlation of cell-free donor DNA in 4 cause biopsies as well as surveillance biopsy. Kind of predict the rejection 2 months or 4 months after the event. And they didn't find a correlation with serum keratin. So the keratin again failed to provide information when someone was going to be rejecting or not. So if I can summarize for a moment for you cell-free donor DNA, and again, there's a lot of publication, but I don't think we have the time because we got to go through a lot of material. Cell-free donor DNA is an injury marker, can detect damage and rejection, has a strong MPV, but PPV is, again, poor, can be utilized as a rule-out test, seems to lack sensitivity in borderline T-cell mediated rejections, but it can be also no specific during infections. Is strongly correlated with antibody-mediated rejections. A recent study, the one that I showed to you, maybe they can provide some prognostic information of future rejection in our patients. Now let's move to genomic test in the blood. So stay away from cell-free donor DNA for a moment and discuss the 3 important tests that we have available today. One is the Graft, commercialized as a Graft. And this was part of the CTOC-A trials, which when I was on Western, was there until a year ago. And there was a run by Mackie Kansas and Dan Salomon, which basically they studied this as a part of an NIH-sponsored trial to look at subclinical rejection in quiescent patients, and patients that have normal serum creatinine, for which you want to rule out subclinical rejections. Originally, this is a microarray. It was a 57 gene marker. Now they report 120, 125 genes. They use a validation set of 138 patients, an NPV about 80% with a sensitivity of 48%, so you have a lot of misses case. And the PPV, again, is still very low, so a flip of a coin, so you're going to have a lot of false positive, especially in transplant center, where typically they don't do protocol biopsy. So if you don't do protocol biopsy, you run this test, you're going to biopsy a lot of patients that don't need to be biopsied. Now, the key source was by Mini Sarwal that had this, that sold the IP to MuneCore, which, as you know, is an important company in transplant. And then when they tried to validate in Europe the test of KeySort, it basically was unable to validate. This was a completely negative study and unvalidated. So KeySort now is off the market. It's no longer available as a test. Then I would like to move to Tutivia for a moment. So there's a little bit of history behind this I would like to just share with you. This started with Barbara Murphy from Mount Sinai. Barbara Murphy and I were very good friends. I'm sure most of you know Barbara. Unfortunately, she passed away some years ago. But we did together a lot of work. And one of the work we did together was part of the GO-CAR trial, which was an NIH-sponsored trial, to really using biomarker to understand pretty much if a specific genomic biomarker can help us to or predict or associate with the rejection or associate with fibrosis. And we published the paper, and then she spun off a company called Verici, and Verici decided to do a large validation trial. And the large validation trial is what we'll present to you today. It was published in AGD 2024. So they include a lot of patients, a lot of countries, US, Europe, and Australia, enroll more than 500 patients. I helped design the trial, and we're still analyzing the data. We're going to come up soon with another manuscript. But basically, the specimen collection is right here. We collect sample 1, 3, 6, 12, 24 months. We did biopsy at 3 and 12 months post-transplant as a protocol. We did all the first-course biopsy, and all biopsy were read centrally, locally and centrally by pathology Tony Chang from the University of Chicago, which I'm sure you know. And then we used BAM classification 2019. I want to point out this was all outcomers. So we basically, the study was including a lot of patients that typically don't get included. All different races, high-risk donor that normally are excluded, expanded criteria, donor after cardiac death, even prior failed organ transplant. And the data I will present is basically the data for the Tutivia, which is the test that now is commercially available, but was done 100 of these 500 plus patients. We were able to reach the power of 151, and then these are all patients that have at least one biopsy within the first 6 months after transplant, all 4 protocol for indications. Protocol was 107 biopsy, indication 44. There was no rejection in 104, rejection in 47. The time of rejection was between 6 and 175 days after transplant. And this is a risk score, is a next generation sequencing or an mRNA signature of 17 genes. And it's a score from 0 to 100. Every above 50 is considered high risk. And all these are little dots, blue and red, are patients. The red are patients that rejects. The blue are patients that don't reject. So these are separations with the statistical high risk of PPV of 60% and the NPV of 79% with odds ratio risk score of 5.74. Interesting, seems that this test performs well in the first 60 days. Of the 44 patients that have indication biopsy, 35 was done in the first 60 days. Of this 35, 24 had rejections, and this 24, 20 had high-risk score. So it seems that in the first few months, or 2 months post-transplant, this test seems to provide inside information. So I just want to summarize briefly about this blood biomarker available to us that are basically the cell-free donor DNA and not the blood-based genomic that I went through. So there might be early detected allograft damage. There's a strong NPV, and the PPV seems to be still not so good. Some assay I show you that can be used sooner post-transplant to support early risk stratification of patients. Some of this test, AI can help us to read the data more. It's new to space to all of us, so we need to really kind of understand it better, how to implement it, and maybe we need to really do more clinical trials to understand the utilizations. They are commercially available. There are multiple one. Cost and turnaround time is a limiting factor. I just showed to you the cost and how long does it take to get the result back. They outperform serum creatinine. I didn't show this, but most of these tests in regards to negative predictive value, they do better than creatinine. This is important to know. So the goal utilization, early detections, personalized monitoring, and medication regimen based on patient individual risk. This is something that needs to be done, and for biopsy indications. Now, I want to show you a little bit this graph because I don't know if you do protocol biopsy or don't do protocol biopsy in our center, but if you don't do protocol biopsy, and you run a test that has a very low PPV, which a lot of these tests have, you're gonna biopsy more than necessary. So this test to indicate you when to do a biopsy in a stable patient, I think they kind of fail. They don't have at the moment because we don't have many tests that with high PPV. But if you have a center that does perform protocol biopsy, you need to have a high MPV to avoid so many biopsies, especially if you're a center that does a lot of kidney transplant, 300, 400 kidney transplant per year. If you do protocol biopsy in all of them, you're going to end up doing 1,000 biopsies or more a year. And as a consequence, you want to have a test with high MPV. And some of these tests have this characteristic, but again, the MPV is not in the range that we would like to be. It's not 95%, right? It's 85, 87, which creatinine is borderline there, right? And then another important question, what to do with unstable kidney patients. So we talk about patients stable here with normal creatinine, which you want to do a biopsy and rule out subclinical rejection. What about the unstable? Which test to use? Well, this is open to discussions, and we need to kind of like do more work on this. But there's a question, this thing. Now, I want to move to bioelectronic and biosensor now to move away from, and this is work that I've done. I've been doing at the moment too, in collaboration with the Rogers Group, with the bioengineering department in Evanston, and all of this started around close to the pandemic area. The idea was, when some of these biomarkers were permeating the clinical arena, and the cost, the statistics were not so maybe we need to think about outside the box. And the idea was that, as you know, during an immune response, you're going to have some biophysical marker changing. So temperature usually does change when you have inflammations associated with any process, including rejections. Maybe even blood flow does a change. Maybe the edema changes, so the stretch change. We show some data. So we decided, okay, let's try to create a device that can monitor the temperature and the surface of an organ, kidney in this particular case, and they can send the information to a receiver that will eventually wirelessly send the information to an iPad, an iPhone, so the information can go to eventually to a medical chart, to a patient, to a doctor, so we can. That this is the idea. So we went through multiple iterations of the sensor, and it took a long time. And during the particular time, if you recall, during the pandemic, it was most of this material that were coming from China. We had issue getting material from China, so we were procrastinating the experiment because everything was blocked. Similar to what might happen to us soon with in US, since we're blocking things from China to come in, unfortunately. But so this is how we design the device. You can see it's extremely small. It's designed to go under the capsule of the kidney. So it's inserted under the capsule of the kidney with a wiring system to a receiver that can transmit outside wirelessly to an iPhone. And this is how this is constructed. So it's a sensor that relies on lithography pattern feature of gold. Is 100 nanometer thick, 20 micron wide, and to form a 3 millimeter diameter thermal sensing disc. And this is the material we use. And obviously, I don't go through the material. I know bioengineering, but you can see how it's being, at least what kind of material is being used to put it together. And the idea was to use a rat model to study this. Two reasons. One, because in rat we can do transplant. I did transplant. I was at the Brigham with the Mosiah and Carpenter's group. I did transplant Northwestern with a microsurgical unit. So in rats, so this was a model that we knew what to do. So the first things to do is like, let's use the sensor, and at least to be able to monitor temperature, internal temperature of an organ, which this is the first time that this has never done, and be able to retrieve the information outside. So at the bottom of the slides, here you can see the figure, right? You can see the sensor inserted in the kidney, the receiver, and then basically extended outside the body. And when we push the sensor, you can see a little bit of temperature variation at the moment because of the surgical procedure, but then eventually the animal enter in the temperature variation due to the circadian model that all mammals have. So we were able to reproduce this multiple times until we were confident that the sensor was measuring adequately the temperature and the surface of the kidney, right? Then we decided, okay, let's move to do the experiment in transplant. Now, we did a set of experiments. I will show you the most important one. But so if you transplant Lewis into Lewis is a strain of rats, you have isogenic transplantation, so typically don't reject. And the native kidney were removed, the kidney transplant was placed into the Lewis rats, the sensor was placed on the surface, and you can see a drop of the temperature after the surgery, but then the animal gets again in the circadian rhythm typically of the mammals. This in the isogenic model of graft acceptance. These are identical rats, basically. When we do an experiment allogenic, which in this case we use ACI rats into Lewis rats, this animal, we do know they reject in 7 days. If you transplant without immunosuppressive therapy, by 7 days they become uremic and they die. So we put the kidney in, put the sensor in, and you can see again the temperature dropping down after the surgery, but then going stabilizing. But then around day 3, 2.5 to 3, there is an inflection point in the temperature right here. When, and I'll show the data in a moment, and then it goes up, and then the animal becomes uremic and dies. Okay. Now we took the creatinine in this animal at all different time points. It was blood obtained from the tail of the rats, or the eyes of the rats, and then we sacrificed the animal. I'll show you the data in a moment. So focus on the top here. So on the top, you have isograft histology and allograft histology. You can see that day 6, this animal, the allograft do reject, and the isograft do not reject because they're identical. Then here you have BUN and creatinine. So BUN and creatinine between isogenic and allogenic is different. So you can see at day 6 a drastic difference in creatinine between isogenic and allogenic. Isogenic BUN is different, and the temperature is also different. They actually become hypothermic in the animal day 7 because of the uremia. But let's focus on day 4, right? Because day 4 was important. When you look at day 4, day 3 to 4, BUN and creatinine between the isogenic and the allogenic is not different. If you sacrifice the animals, the isograft don't have rejections as expected, where the allograft have rejection. The only difference that there is between that we were able to measure is the temperature. So the temperature at day 3 was elevated in the allograft animals, and in the animal that received an allograft from the ACI, and compared to the isogenic. So again, the temperature was the only signals that a rejection was occurring in the kidney of the animal receiving the allograft. Obviously, this is not an experiment that you do in humans because humans receive anti-rejection therapy. So we decided to do an experiment now with immunosuppressed therapy. So what we did, we give this animal now 7 days of Prograf and then stop. So we want to mimic a little bit non-compliance to some extent. And again, this is the graph. The top here is basically the isograph, and all the bottom here are all basically allograft. So here, the shaded area after the surgery is the 7 days of Prograf, and then stop the program. So we check serum creatinine at day 4, 7, 10, 14, 20, and 27. and they were all normal, all within the normal range. And only at day 27, creatinine BUN went up. But then we look at the temperature. At day 7, it was stable. But when we stopped the Prograf, at day 10, it started increasing, and it peaked at day 14, right here. You see the arrow right there. And then we sacrificed the animal. There was rejections again within the allograft. So consistent with what I was telling you before, that basically temperature again becomes an indication of some event happening in the graft before the standard monitoring tool that we have, which is basically creatinine in this case and BUN. So we envision this to eventually be used as a device that can be placed in the kidney, and then a receiver to the end can be a cellular phone with an alert that can be eventually interface with Epic or whatever medical records you have, which is so in other words, now the doctor or the patient gets alert. You also know the patient have, I don't know, I know that transplant nephrology and they're in the Zoom call, but the truth is that patient feels so nervous, and I think to have something that gives information about the health or no health of the kidney can be an important piece of mind for them. So there's two pieces. There's a scientific piece and also a psychological piece, to my opinion, that we have not investigated. Obviously, these are all animals. So I want to tell you that now we are moving to large animals, because after this experiment, we would like to move to humans. So obviously, we had to redesign the entire sensor. And the size of a kidney in a pig is identical pretty much to the size of a kidney in humans, up to 40 kilograms of a pig. Obviously, pigs can go much bigger. But, when you take a pig about 40, 45 kilograms, the kidney is very similar to a kidney of a human. So we redesigned the entire probe, the entire things. This is how now is being designed. We still have the same sensor that goes under the capsule of the kidney. We have, again, a receiver. It all transmit outside to a cellular phone. It was a little bit more complex, to tell you the truth, in pigs, because you got to put a vest. The way do you put the phone? The pig tends to, they go around all the time. So we went through multiple problems. The pig also is a very difficult animal to transplant, very sensitive to evisceration. So we had to learn how to do the kidney transplant from scratch. There's not much literature about how to do kidney transplant in pigs, believe it or not. So you need an entire operating team. Anesthesiologists, the pig needs to be intubated. They need to have at least 1 or 2 transplant surgeons. So it's a lot of work, just put it this way. But we were able to do, and I'll show you some of the data. So we planned this a continuous monitoring of a sensor, one of the skin and one of the kidney. And again, you can see this is not a transplant yet, but you can see the temperature, going to the circadian rhythm, typical mammals. We have animal up to 2 months with the sensor. We see the temperature in the native kidney. This was done on native kidney. Then we did an experiment in a transplant kidney, and I'll show you some data in a moment. So what we noticed, this was an animal in which we removed the native kidney, okay? We put the transplant kidney, and then we monitor temperature and creatinine. You can see here the day, this was around December. You can see that by day 2.5, 3, the temperature goes up, but the creatinine is still relatively normal. Now, unfortunately, this happened on Friday, so the animal then we were not able to capture all the information appropriately. But anyhow, the message is that we are consistent data. The temperature increase in allograft in pigs occurs also before serum creatinine. We also did an experiment which we put the sensor. This experiment, may be specific, is done in an animal in which the native kidney are still in place. So there's no creatinine in this particular one, because we want to really understand when this animal rejects. They come from different farms. They are different type of haplotype, because they come from different. These are not like rats. They're the same HLA. Sorry, the same kind of equivalent, the HLA and the rats. I don't know how to call it, but for the pig is SLA, swine leukocyte antigen, and they come from different farms. So that even though we try to to mix and match, sometimes we have animals that we type them, they're completely different, and sometimes they're very similar. And so we decide to stay away a little bit from taking the kidney, native kidney out for the moment. It just implanted the kidney transplant so the animal and to see understand when they reject. We do, and typically they reject around, again, around day. We have sacrificed them early, but around day 2 or 3, even though temperature variation seems to occur even earlier, around 1.5 to 2 days after transplantation. You can see at the top going up in the transplant kidney sensor compared to the sensor in the native kidney. And then we place also a strain sensor. A strain sensor basically is a sensor that measures edema within the graft. As you know, when you are rejection, this is a lot. Every time you do a biopsy, I'm sure you see it. You see infiltration of T cell, and the pathology will tell you that there is edema. So we are actually looking at tissue edema and temperature combined together. You can see at the bottom here, around day 1.5 to 2 days, there is edema going up, or stretch going up, I will say, in the transplanted kidney. As you can see that when we sacrifice the animal, the size of the kidney, you look at the size of the transplant kidney, this animal without immunosuppressed therapy, much bigger compared to the native kidney, the same animal. So obviously they enlarge in size when they reject. So I would like to, in the biosensor transplant, I would like to say that biosensor detect rise in kidney temperature and of disruption of the circadian cycle associated with the kidney transplant rejections. This warning sign of acute transplant rejection precedes changes in blood serum creatinine by 3 days in rats and without immunosuppressed therapy, in 2 to 3 days in rats model kidney transplant with immunosuppressed therapy. Similar, this also in pigs. I think the possible future utilization of biosensors is to guide the clinical use and timing of some of the biomarkers I discussed with you before. These are very expensive biomarkers. You cannot really use them, all the time. So maybe if we create some sensing mechanism that we have in humans, we can maybe decide when to order this test. And continued temperature monitoring with other biophysical measurement by implantable bioelectronic system could provide valuable information for kidney health. I'm going to stop here and take any questions. I want to just thank at least the people that work with me on this. Obviously the John Rogers group, which has published a paper 2 seconds. Yesterday in Nature Medicine review regarding all the sensory that can be used for kidney health, including sensing for creatinine in the skin, some of the microsurgical score. All the group at my institution that did all the surgery. Tony Chang from University of Chicago that did all the reading for the biopsy, and obviously the BRL, the Biological Research Laboratory here, where all the animals are hosted and most of the experiments have been done. And I stop right here and I take any questions.
Thank you very much, Dr. Gallon. So if you have any questions, please raise your hand or you can put it in the chat as well. That was fascinating. And maybe I'll start with some questions while we wait for some of the questions to come in. Can you, just to give us a sense of reference, can you tell us what you do at your center in terms, are you a protocol biopsy center or are you a cause specific?
We are a protocol biopsy center and I'm sorry, protocol biopsy center, sorry. And we do use biomarker after transplant. We use a lot of cell-free donor DNA, mainly because we do a lot of the ABO incompatible and highly sensitized patient here. Sometimes we take organ with maybe low MF5 at the time of transplant. So we tend to be more proactive in monitoring, and given the fact that humoral rejection seems to be linked to cell-free donor DNA release, we do use a lot. But I can tell you that, by implementing this test routinely, we are doing more biopsy than necessary, I think. In fact, the pathologist called me 2 days ago, said that, I'm biopsying too many patients. I cannot keep up with the number of biopsies. So yeah, this is where we are at the moment. Yeah.
And do you use your cell-free DNA on like routinely on everybody, or do you specifically use it for higher risk patients?
Yeah, it's a protocol. So it's part of the protocol in
Are
our
your
patients. Yeah, so you're right. We should be using for specific subpopulations. But the truth is that, as you know, it's not so simple to implement all this protocol to all patients. So we decided to say, okay, let's do for all of us, for at least in the first year. I think we checked 3 times to be specific.
Mhm. Just to give you a landscape of Alberta, because I worked at both centers now. So neither of our centers are protocol biopsy for adults. I can't speak for peds. I think our Calgary pediatric program is still a protocol biopsy center for the pediatric patients, but our both our adult programs are indication biopsy centers. There's actually only maybe a few centers across Canada that do protocol biopsies still. I believe Winnipeg is obviously is a big with Dr. Peter Nickerson is a big protocol biopsy center, and I believe there's another one or two in Quebec that do protocol biopsies. But I would say the majority of the centers across Canada are indication biopsies, and as far
Yeah.
as I know, are not routinely using cell-free DNA as a biomarker, but there is definitely interest in that, I think, as the research evolves. Yvonne, you had a question as well. Did you want to unmute and ask?
By the way, Lam, I don't see the chat. So if that question on the chat, will you mind to just
Yes,
pick
of
them up?
course. Yeah, yeah.
Thank you very
Yvonne,
much.
did you want to unmute and ask your question, or did you want, I can read it out loud as well.
Yes, I can do it. Thank you so much. Doctor, thank you so much for your presentation. I am a 35, well, my age is 57, but I was transplanted 35 years ago. So I'm blessed because I'm still alive and doing very well. Um, but the fact of the immune suppressants after so many years of being transplanted have taken a toll in my overall health in many ways. Of course, it is a blessing that I'm still alive, but the quality of life has also been a challenge. So I keep on asking this question because I was requested by many, even the medical community, to do so because there could be more fundings into this type of research as of when and how, if ever, we'll be able to be off the immune suppressants or reduce them, or now that you're mentioning, to have a more personalized approach into how much we need or not, because they're nephrotoxic in themselves. So how can we just have the limited or minimal amount of immune suppressants after a certain amount of years, let's say?
Yeah. So this
Imagine
is a good
35.
question, and congratulations for having your kidney for 35 years. It's amazing.
Thank you.
Very good for you. And yeah, so you're right. So the across the street there's a friend of mine called Joe Levent that has done a lot of work on tolerance, and he published beautiful data. It does require you know, the transplant of a bone marrow from the same donor that gives the kidney. Okay, and there is a no conditioning regimen or immunotherapy that reset pretty much your bone marrow to accept. The data is quite good. In fact, right now, I think they're trying to do a multi-center. Now, the problem with this type of approach, which is basically induced tolerance, it does require a lot of upfront chemotherapy. You got to really almost like you have to receive a bone marrow transplant. So it was difficult to do a multi-center trial, even though I think is working on this in an outside country, because the patients, number one, because you need a lot of people to do it. You need an hematology, you need a transplant surgery, you need nephrology, you need an entire team to do a bone marrow kidney transplant. So it's quite of a task. Now, to other question that you asked before regarding minimization, my opinion is a lot of our patients are most likely over immunosuppressed. They take more than what is necessary. The question is how you identify those patients, right? I you know, I do believe that the new way of HLA typing with the perch and other technology available in the future, because at the end of the day, isn't a new system recognizing foreign antigen, right? And then I think if you are able to identify how many of these antigen carry immunogenic peptides or applets, I think we might be able to minimize the exposure in patients which that degree of mismatch in terms of the score, I will say, is lower. But this needs to be done in a clinical trial. I mean, I cannot empirically do it in my patients without designing a trial that makes sense, right? So also because my understanding when we use cadaveric kidney, the percentage of patients with a low perch score, which I showed this before, so maybe I can go back to, I know I don't want, no, I go back to this one here to so you understand maybe a little bit better what I'm saying. Oh no, sorry. There you go. So, when you look at an HLA antigen, all this yellow part are mismatched peptides. When you do regular matching, we just take the entire antigen. Here you go deeper into the antigen per se. Within the antigen, you can see the mismatched peptides that are being recognized by the immune system. If we're able to somehow do a trial or trials where by doing this molecular matching or mismatching, you can decide who has more or less, as a consequence, who you will give more or less anti-rejection therapy. It would be a big step forward towards what exactly you ask.
Sean, you have your hand up?
Yeah, there's actually, I think, three of us on the line that have had transplants. And I mean, obviously, we're walking experiments, having, an organ put into us in the first place. But I'm curious, as you move from the mouse model to the pigs and now to human trials, what do you envision the pro, con, and consent conversation look like going with your first human patients, to receive, something mechanical or electronic to be attached to their kidney? Like, it's a fascinating device, but most of us aren't packing around batteries on our insides right now. I'm literally flying tomorrow morning at 6 a.m. and I'm thinking, hey, would that set it off like a pacemaker?
Yeah. No, you're right. Well, we're working. Okay, let's put it this way. I mean, you are patients. I don't know how frequent you do your labs. Most of my patients do once a month labs. What I
Yeah,
notice all the time, when they get like a 27 days after the last time they did the lab test, they start getting edgy, nervous, how my creatinine will be, et cetera, et cetera. So I think we need to. I think the fear. I mean, okay. So the question is, listen, our existence allow us to see only what we see, right? You have to fast forward these 10, 20 years, right? Maybe more. And I do believe that we will be able to insert small devices, smaller than the one you see here,
hmm
that can gather a lot of information, more the information that I showed you today, um, through small batteries. I understand what you say about batteries, but honestly, like you said, people are pacemaker. Um, and then send the informations wirelessly to different places, right? So at the moment, as I think about this, how is going to be the first patient? So one thing that I have discussed with my collaborator is that the device has to be smaller. I would like to, I mean, the part of the wire at the moment is still, unfortunately, um, there. This part here that you can see in the picture, the part behind the sensing part, is placed at the moment into the fat of the abdominal wall, okay, between the fascia there. So because we believe that is a good place to be, because that can be recharged with with a magnetic field from outside eventually when we go to human. But you're right. I mean, I don't think we are ready for prime time, but I do believe that we need to think in that directions, because having a device that can inform through temperature, blood flow, or stretch, or whatever we want to be able to do, can be a red flag to the patient to go to the ED or go be seen by a physician. Many times I lose patients, I mean, kidney transplant, because they don't go and do labs for months. You know this, right? It happens quite frequently. About 10% of my patients don't take medications. So they're not like you, I mean, very engaged in their organs. They are all young kids, teenagers, or they are people that have sometimes, unfortunately, no money for pay for medications. So having something that informs them and us what is happening, I think is an important effort. I'm not saying that we're going to be able to do it anytime soon, but we are working with the bioengineering to just create something that is more, in line. Remember, the kidney transplant is being placed on a back table where it can be manipulated before it gets inside the body.
Yeah, it'll be interesting when it gets to that prime time how patients will accept it. Will they accept it like a pacemaker where it's monitoring something, or will they reject it? I mean, we have a hard time getting patients to take their COVID vaccine because they think Bill Gates is putting a tracker on them. So is this going to be like a conspiracy theory?
Yeah. Well, yeah,
But I
you're
guess
right.
one last question, just to be clear though, your bioelectrical sensor senses changes in edema or temperature, but can't differentiate between whether or not the damage is due to rejection versus, other causes of temperature or fever and edema like BK or UTI or something like that. Is that
Yeah, very important question. I think probably, yeah, you're right. No, this, we cannot at the moment, we cannot distinguish between. Obviously, we are not done the experiment. I think the reviewer asked us to do an experiment in. Let me think, because it's not on the paper. We were trying to do an experiment where we induce the animals with a toxin to induce basically infections. And most of the time, in that case, in animals, the temperature goes down, they become septic, and they die. So the only way to test this is in human, and you're right, this is not specific for transplant rejections. It can be probably elevated also in a pyelonephritis, but maybe there are patterns of a pyelo, for example, UTI pyelo or fevers related to an infection that are different than the pattern that we see related to rejections. But I don't have the data because I never done it. I mean, the only place that you can do this kind of experiment is in a human, right? Because there you can have, because to do an infection in pigs, it's not simple, right? I mean, it's complicated in the rats, and it's even more complicated on a pig. So I don't have. How can I induce a UTI? In a pig?
Yeah. No,
Right.
it's very exciting, very fascinating stuff. I hadn't heard of these this bioelectrical sensors. It's very interesting to see what comes of it. Just the interest of time, thank you so much, Dr. Gallon, for a very interesting talk. And I just want to let everybody know that on May 7th, there's a hybrid seminar with Dr. Lorna Marson from the University of Edinburgh, which will be in Classroom D at the U of A Hospital or online via Zoom. And if you go in person, there's a light lunch. So they'll be talking about challenges and opportunities in clinical academia. So I hope to see everybody there. And again, thank you so much, Dr. Gallon, for this.
Thank you. Thank you. It was a pleasure. It was a pleasure. Thank you for the invitations.
Great.
Yeah.
Bye, everybody.
Thanks, everybody. Thank you, Dr. Gallon.